Hi, Miss Nikki here. Welcome to Chapter 26. We're going to discuss fluid and electrolytes. You can see here average intake versus average output. And you can see it should be about the same. It should be 2.5 liters or 2,500 milliliters. So where do we get the intake from? Where do we get water from in our daily lives? Well, beverages that we drink, foods that we eat, and then from metabolism. So the breakdown and buildup, there's going to be a little excess of water. Remember, cellular respiration byproducts are CO2 and water. In your output, what are you releasing? Well, urine, sweat, some in the feces, and this insensible loss. So via the skin and the lungs. So remember, when you have that bicarbonate buffer system and you drive that reaction backwards when you get to the alveoli, you have CO2 and water. So we talked about some water vapor that's present in the lungs. And then even if you don't know that you're sweating, there is something called insensible. You can't feel it, but you do sweat during the day. One of the things to kind of pay attention to here is this should be equal. So the beverages, the liquid beverages that you consume shouldn't end up as urine. So sometimes if you're trying to watch somebody's fluid intake, they're going to measure everything that you drink, and they're going to have you measure everything that comes out in urine. And if it doesn't all come out, well, that should tell you that you've got some issues, right, with your glomerulus or nephron in general. Total body water is about 40 liters, but it's based on a few factors here. So if you're an infant, you have more water. If you're a male, you have more water versus a female who has less. This has to do with males have increased muscle mass, and then females have increased fat mass. And so fat, if you have high fat, less body water. So adipose tissue is the least hydrated of all. And then obviously as you get older, since you have a decrease in muscle mass, that's probably also going to affect and cause a decrease in body water. If we wanted to break our total body water down into sections or cavities, we would have intracellular, so this is inside the cell, or intracellular fluid, ICF. So let's go ahead and just draw a cell. This would be our plasma membrane, right? Remember when we talked about resting membrane potentials, we kept talking about how there's lots of potassium on the inside of a cell, and then there's also these really large phosphate molecules, right? And that's what helps set up that -90 or -70 millivolt resting membrane potential in muscles or nerves, right? So if we know that we have potassium on the inside of our cells, what do we have on the outside? Hopefully we remember our sodium, right? So in the extracellular fluid, that's anything that's outside of the cell. So that's not only interstitial fluid, but that's also the water that's in your plasma. So extracellular fluid includes both IF, or interstitial fluid, and plasma. So extracellular fluid, we're going to have sodiums, we're going to have chloride ions, and basically just understand intracellular, inside the cell, what are the major ions that would be inside, and then extracellular, what are the two subcategories of extracellular, and then what ions would you find there. Hopefully by now we know these terms. So water is the universal solvent. Solutes are the items that get dissolved, right? And the result is a solution. We also use these terms a lot, electrolytes and non-electrolytes. So if you're a non-electrolyte, they do not dissociate in water. Glucose, lipids, urea, no charged particles are created. So what's an electrolyte? If I take salt and I put it in water, what happens? It dissociates into ions or charged particles. This is a nice figure from your book, kind of showing you the different electrolytes or most common electrolytes, and then which compartment you would find them in. So we kind of just talked about this. Where do you find sodium? You mostly find it in the extracellular fluid. Remember, blood plasma and interstitial fluid make up extracellular fluid. Where do you find the most potassium? Intracellular fluid. Where are you going to find these hydrogen phosphates, these really large negatives? You're going to find those in interstitial fluid as well. Where are you going to find chloride? You're going to find that in the extracellular fluid. We need to talk a little bit about fluid movement and exchange between compartments. We already talked about osmotic pressure and hydrostatic pressure, and we talked about how it diffuses or moves carbon dioxide and oxygen between the capillary beds. Right, we said capillary beds, and it moves it to the interstitial fluid, and then it moves it inside the cell. And this is all forces. Well, this can also cause the exchange and the mixing of fluids. So this term here, osmolality, you might be familiar with the term osmolarity. In the human body, these are the same. They're different, but not by that much. We kind of just use them interchangeably. But osmolarity is looking at solutes per liter. And then osmolality is looking at the concentration or amount of solutes by weight. But again, for us right now, it's the same. So what they're saying is, what happens if you have high solute concentration? So they're saying if you have high solute, and where is it? High solute outside, extracellular fluid. Maybe if I draw a picture here. So high solute out here. What's going to happen to the cell? What's going to happen in the intracellular fluid? The water is going to go to wherever the solute is high, right? Water follows the high solute. And then in this case, if the extracellular fluid has low solute, outside is low, where's the water that's outside the cell? The water is going to go inside. So what they're saying is that the fluid can be exchanged between the extracellular and the intracellular fluid based on osmotic pressure. Another image here, just kind of showing you what we talked about. Can we move oxygen and carbon dioxide from the blood plasma to the interstitial fluid into the cells? Yes. Can we do the same thing with water? Yes. And what is it usually based upon? It's based upon, the water movement is based upon solute concentration. If you have high solutes out here, if you have extracellular high solutes, water is going to move out of the cell to try to dilute out the high solutes. If you have low solutes in the extracellular fluid, what's going to happen? All the water that's in the interstitial fluid is going to move and rush inside the cell. Right? So water is going to wherever the solute is in a higher concentration. When we looked at that very first slide, we talked about water output and intake, right? They must equal. So we said it's about 2.5 liters a day. Water's taken in mostly through foods and beverages, a small amount from metabolism. What we really want to focus on is what is kind of the regulation here. What's going to happen if your solutes are too high? So you have a rise in solutes. That means if you have high solutes, you probably have low water in comparison, right? So this is going to stimulate thirst so that you take in more water, and it's also going to cause antidiuretic hormone release. What does antidiuretic hormone do? Increased water reabsorption in the kidneys, right? So what's the opposite of that? What happens if your solutes are too low? That means you've got enough water, right? It can inhibit thirst, right, and cause the inhibition of antidiuretic hormone. So stop drinking, stop releasing ADH. Let's talk about the thirst mechanism a little bit more. So what causes you to be thirsty? So basically your hypothalamus with its osmoreceptors detect that your plasma solute concentration has increased. So increased solutes, only by 2 to 3%, are going to trigger the osmoreceptors to send a message to the hypothalamus so that it can stimulate some sort of response, right? It can cause dry mouth. So this is mucus increase. Remember, we have serous, which is watery, but we also have mucus glands. So we can increase mucus, makes your mouth dry, sticky. This high solute here is going to affect your blood volume or your blood pressure. If you have high solutes, that means you have less water, right? We're looking at the amount of solutes in a volume of water. So if your solute concentration has gone up, there's too many solutes and not enough water. So this can decrease blood volume, blood pressure, and then what would that trigger? What organ does that angiotensin, basically back it up, what triggers angiotensin to be formed? So hopefully you're saying, renin, hopefully you're thinking about those granular cells in the kidneys, right? That are, I don't know why I put apostrophe. Well, there we go. So also baroreceptors. Remember baroreceptors in the aortic arch? They're measuring blood pressure as well. So all of these things are going to cause you to want to drink more water, right? So this is what triggers our thirst mechanism. As soon as you start drinking, so as soon as you start drinking water, it'll inhibit that thirst center in the hypothalamus. You have to be careful though, because this doesn't mean that you've consumed enough water. It's almost like as soon as you start drinking the water, your brain goes, okay, I feel better now. But you actually might need more water than the water that just hit your mouth, right? You might need more than one sip. Before we move on, I wanted you to see that we do have some water that's going to leave no matter what. So feces, sweat, which would be sensible or insensible, water loss that we can't feel, we're losing this water every day no matter what. So this is kind of in a perfect world, we would drink as much as we need and it would come out as urine. But if you dropped this down, if you didn't drink anything all day, obviously that's going to affect your average output of water. So this slide is saying that drinking is necessary, right? We have obligatory water loss. We have this insensible, we have feces, we have sensible water loss in terms of sweating. So beyond just these obligatory water losses that we have every day, solute concentration and the volume of the urine is dependent on the fluid that we take. Remember that water and sodium are regulated in tandem, right? We talked about co-transportation. And we need enough water in order to maintain our blood pressure. So it is important. Let's talk about ADH regulation for a second here. So do we remember what ADH does? If ADH is on, we're going to have increased reabsorption of water. Where does that happen? Collecting ducts or distal convoluted tubule. Remember, if we're talking about reabsorbing water due to a hormone, that's happening at the end, the collecting duct or the distal convoluted tubule. If I talk about reabsorption at the loop, nephron loop or loop of Henle, that's not directed. Remember that nephron loop? That is not directed by hormones. That's just directed by solutes and kind of the flow. Remember, we talked about the countercurrent exchange and multiplier. So you can go back and look at that in urinary. But basically, if ADH is on, you're going to reabsorb water. So think for a second, if you reabsorb water, more water is going to mean more, like higher blood volume, right? Higher blood pressure. So kind of still make all those links together. Also, if you're reabsorbing all the water, ADH is on, you're reabsorbing water, what's happening to your urine? If you're not letting the water go into the collecting duct, that means your urine is going to have low water, and that means your urine is going to be concentrated. So what about ADH off? If ADH is off, you're not going to reabsorb, so decreased reabsorption of water. That means low water, low blood volume, lower blood pressure. What does that mean for urine? So you're not reabsorbing the water. You're not putting it back into the bloodstream. So where is it going out? That's right, it's going out in the urine. So you have increased water in the collecting duct, increased water in your urine. So if you have more water in your urine, instead of being concentrated, it is dilute. That's what this is trying to say. If you have low ADH, or you're turning it off, you're going to have dilute urine and decreased volume of bodily fluids. If you have increased ADH, if ADH is on, you're going to have concentrated urine and you're going to have increased blood volume or increased volume of bodily fluids. And what's the trigger for this? Do we remember where ADH is stored? Do you remember ADH is stored in the posterior pituitary? But do you remember the posterior pituitary? It's released on those axon terminals, and there is a nerve that goes up to the hypothalamus. So if you remember when we talked about ADH, we said that it's made in the hypothalamus, but then it's stored in the neuron endings in the posterior pituitary. So this is all being triggered or regulated by your hypothalamus. Let's talk about dehydration. So if you have low amounts of water, here are all the causes, right? It could just be you're not drinking water. You're running a marathon, profuse sweating. Could be some sort of drug interaction, hormone disturbance. Could be that you're bleeding out, right? Hopefully this will trigger that thirsty, dry mouth sensation due to the hypothalamus. And then this one is low urine output. So very little urine, thirsty all the time. This can lead to weight loss, fever, mental confusion. And this is the probably most important, is that if you have low water, you're going to have low blood volume, and that's going to lead to low blood pressure. And this can also influence your electrolyte balance, like your sodium and potassium. Let's look at dehydration in terms of this figure. So this line right here, this is outside of the body, and this is inside the body. And remember, we talked about you have two compartments. Well, you have multiple, but in this case we're going to look at these two. You have extracellular fluid, and here you have intracellular fluid inside the cells. So I like this figure because it's showing you've got like a spigot, right? And it's open and water is gushing out of your extracellular fluid. So the water in your extracellular fluid has gone down. Well, remember, we can switch fluids between the extracellular and the intracellular, but it's based on solute concentration. So let's say I'm losing water, so my water in my extracellular fluid is going down. That means my solute is high, right, relative to the water. If my solute is high, what happens to all the water that's inside the cells? Water goes to wherever the solute is high. So the water in your intracellular fluid is going to go out to your extracellular fluid, and that's going to cause your cells to shrink. Now to look at the opposite, this is hypotonic hydration, or most people would say overhydration. Remember, hypotonic just means low solute, the hypo part, right? Low solute concentration in water. So the solute is low compared to the water, which is high. So overhydration or water intoxication. Basically, you're going to see a decrease in solutes. In this particular, this is a decrease in sodium. You're going to see the swelling of cells, the opposite, and I'll show you the image in just a second. What can this cause? Metabolic disturbances, right? So breaking things apart and putting things together, it's going to cause issues. Nausea, vomiting, muscular cramping, cerebral edema. What's this muscular cramping? What does this have to do with? Well, you've got to have the right amount of electrolytes on the right side of the muscle cell, right? So this can also cause swelling in the brain. There's no place for that fluid to go, right? We've got the meningeal layers, we've got the skull, so possible death. This example mirrors the other one that we looked at. So this is outside and this is inside the body, right? So you take in excessive amounts of water. The water is really high in the extracellular fluid. If the water is really high, the solutes are low in comparison. What about in here? If these solutes are low, in comparison, these solutes would be high. They're not isotonic. Remember, isotonic was if the solute concentration was the same. So these solutes inside the cell are high compared to the solutes outside in the extracellular fluid. So where does all this extra water go? The extra water in the extracellular fluid is going to go inside intracellular fluid, and that's going to cause the cells to swell. We already talked about edema in the cardiovascular chapter, but remember this is an accumulation of fluid somewhere in the interstitial space. So basically anything that causes the fluid to be pushed out faster or hinders the return of the fluid. Remember we had to go from cells to interstitial fluid and then to the capillary. So basically fluid that's stuck in this area, so if you have increased water in this area, that is edema. Let's just take a quick look at sodium. Remember, sodium is the most abundant cation in the extracellular fluid. Remember, it's outside of the cells. Why is this important? It controls fluid movements, because remember, wherever sodium goes, what follows? Water. And remember, it's responsible for excitability of nerves and muscles. Remember, we have sodium on the outside and we have potassium on the inside, and it sets up that resting membrane potential. So changes in the plasma sodium level can affect volume and pressure. And then remember that it's also there to control or be monitored by the macula densa. You remember the macula densa cells that monitor the amount of sodium chloride in the filtrate, and then it can trigger renin, angiotensin, which then triggers aldosterone. Go back and review aldosterone and the renin-angiotensin. Remember, aldosterone causes the reabsorption of sodium, which causes the reabsorption of water. The renin-angiotensin, the main trigger for aldosterone release, triggered either by the sympathetic nervous system, your fight or flight. If there's something wrong with the filtrate, osmolality, so too much sodium going out, that was the macula densa I just talked about a second ago. So just go back and look at those two again. Clinically, you might go back and look at Addison's disease. So if you had a low amount of aldosterone, so you don't produce any aldosterone or very little, then you're going to have a lot of sodium and a lot of water in the urine, and you're constantly at the risk of having low blood volume or hypovolemia. Usually, if you can ingest enough salts and fluids, you can avoid that sodium balance problem, but obviously it would play a role here. Also remember your atrial natriuretic peptide, ANP. So released by the atrial cells in response to stretch. So if your blood pressure is too high, this was the only hormone that we talked about that decreases blood pressure and blood volume. So it's going to inhibit ADH, the renin, aldosterone mechanism. It's going to cause the secretion of sodium and water. Because what are we trying to do? We have high blood pressure. We're trying to make it go low. So we're going to get rid of sodium and get rid of water. Also promotes vasodilation and decreased production of that angiotensin renin mechanism. Sex hormones also play a role here. Estrogen can increase sodium reabsorption and lead to higher retention of water, and this happens during menstrual cycle and pregnancy. Remember that estrogen peaks at the end of the ovarian cycle. Progesterone does the opposite, so it decreases the sodium reabsorption and causes water loss. So sodium is also regulated by baroreceptors. So remember, baroreceptors detect increases in blood pressure. If you have high blood pressure, that can stimulate your sympathetic nervous system, that fight or flight, and that can tell the kidneys to decline or stop producing, right? We want to inhibit the excretory function. We don't want to have to stop and pee if we're doing fight or flight. Afferent arterioles can dilate. Glomerular filtration rate will increase. And if I increase the filtration rate, I'm going to have more sodium and more water output. So that means increased urine output. And if I have increased urine output, my blood volume and blood pressure is going to go down. We also have to talk about potassium balance. What happens if you have too much potassium in the extracellular fluid, and what happens if you have too little potassium in the extracellular fluid? So remember, this affects the resting membrane potential. So remember, if we have extracellular fluid here and intracellular fluid here, inside we're supposed to have potassium, and outside we're supposed to have sodium. Now we also have those really large phosphate molecules that make this resting membrane potential either -90 or -70 millivolts, depending if you're a neuron or a muscle. But what happens if you have too much out here? What if the extracellular membrane becomes extra positive compared to the intracellular membrane? Well, that can cause a decrease in the resting membrane potential. It can cause depolarization. What happens if I have not enough? So I have none of these, no potassiums in the extracellular fluid. Well, that can cause the inside to become even more negative. Remember, we talked about hyperpolarization. We had this was threshold, and we saw the action potential go up and come down, and then this was our resting membrane potential, and we said if it drops below, that's called hyperpolarization. It's harder for that neuron or that muscle, either the neuron to fire or the muscle to contract, right? If we're hyperpolarized, it makes it harder. So what do I want you to get from this? One, I would know these terms. Hyperkalemia means too much potassium. Hypokalemia means too little. And realize that if you mess with the amount of potassium, it can interrupt or displace the resting membrane potential, and that, if we're talking about the heart, it can interfere with our electrical conduction, and this can lead to sudden death. Potassium can also be controlled by aldosterone. If you remember, sodium and potassium are linked. So let's say this is blood where I want to reabsorb, and this is secreted. This is going to be urine. It's going to go to the collecting duct and become urine. So remember, if I reabsorb sodium into the blood, I have to kick more potassium out into my urine. So aldosterone can have an effect on the potassium balance because of this interchange, because they go the opposite way. You have to be careful if aldosterone isn't working properly, specifically with some foods, like salt substitutes are really high in potassium. They're low in sodium, but they're high in potassium. If your aldosterone mechanism isn't working properly, so you have no aldosterone, you can't reabsorb sodium, but you also can't get rid of potassium in your urine. So you'll have a high level of potassium in your extracellular fluid, and this can lead to issues. The last electrolyte that I just want to review is calcium. So remember, calcium in the extracellular fluid is important. You need to have calcium in the extracellular fluid for cardiac, right? Remember, we talked about the fact that we have to have lots of extracellular calcium in order for cardiac contraction to occur, or to have that plateau, that long extended contraction or action potential. And then also you need calcium in your extracellular fluid for blood clotting. So hypocalcemia, that's if you have low blood calcium levels, and hypercalcemia, you have high. And again, it's like the Goldilocks. You really don't want too high and you don't want too low. You want to have that calcium balance. And hopefully you remember the two hormones that help us balance our calcium levels. Infants are more sensitive to fluid and electrolyte imbalances because they have more extracellular fluid until they're about 2 years of age. So they just don't have as many cells, right? So you're going to see acid-base issues, you're going to see lung volume issues, fluid intake and output is really high, high metabolic rates, meaning you're creating more waste, high rate of insensible water loss. They're losing a lot more water. Remember, they have more total body water. It was like 73%, right? So the first month of life, you have a real risk for dehydration or for your blood becoming too acidic. On the other end of the spectrum, if you're older in age, total body water is going to decrease. Remember, it went down to 40 something. It was around 40. And we're going to have homeostatic mechanisms that slow down. So that receptor to control center to effector, that's going to slow down. Elderly may be unresponsive to thirst cues. That should tell you something about the hypothalamus, right? Maybe the message isn't getting to the hypothalamus. Maybe it's not detecting that you have low body water and you need to drink more. So this puts elderly people at a higher risk for dehydration. You have less water and things aren't working as well as they used to, right? And then if you have any other conditions like congestive heart failure or diabetes, this can lead to fluid, electrolyte, or acid-base problems that we're going to talk about in just a second. I'll see you part 2. Bye.